Excellent. Welcome, everybody. Welcome to BC Women's Research Rounds. As some of you may be aware, there is a bit of a global Microsoft technical glitch this morning, and it is keeping all of us health authority folks, many of us locked out of our workstations. So thank you for being patient with us this morning. Zoom appears to be unaffected and we're up and running, so we're very thrilled. So thank you. I just want to start by acknowledging that we're coming to you today from the unceded traditional territories of the Coast Salish peoples, including the territories of the Musqueam, Squamish, and Tsleil-Waututh nations. We're extremely grateful for their stewardship of the land over time, and I know many of you are joining us from different traditional territories, and I would really just encourage you to, give a thought to where you're joining us from today, especially as we enjoy this beautiful weather, but we're also reminded of the volatility right now with the fire season. So just sending good vibes for the land right now. I am thrilled to be able to introduce today's speakers, and my assistant is going to help me pull that up. Excellent. So Emilie Theberge, my apologies, is a researcher at the Women's Heart Clinic under the supervision of Dr. Tara Sedlak since 2021, and she's currently a UBC Medical Genetics PhD student under the supervision of Dr. Anna Lehman. And together with Dr. Sedlak and Dr. Lehman, Emilie is conducting research at the intersection of heart disease, clinical genetics, and sex differences. And we're also thrilled to be joined by Elizabeth Burden, who's a third-year internal medicine resident at UBC, who has been working with Dr. Sedlak and Emilie at the Women's Heart Clinic since 2023. Liz has an interest in pursuing a specialization in cardiology, specifically focusing on women's heart health. So welcome to today's speakers, and I'm going to give the floor over to you.
Thank you so much. Just want to confirm that you can hear me okay? Can you hear me?
Yes, we can. Thanks, Em.
Perfect. All right. So first of all, hi, everyone, and thank you so much for joining us this morning for BC Women's Hospital Research Rounds. And thank you so much to the WHRI team and BC Women's Hospital team for inviting us to share our research. So today, my colleague Liz and I will be sharing some lessons learned from 3 years of follow-up at a specialized women's heart clinic here in Vancouver. So today we'll begin by briefly introducing the Women's Heart Clinic core team, then provide an overview of the diagnoses that we specialize in, MINOCA and INOCA, and then speak to the connection between mental health and heart health as relates to our research findings. And lastly, we'll speak to some results from our recent paper demonstrating the impacts of a women's heart clinic on women who've been in our research registry for over 3 years. So who are we to speak to these topics? So on the left, my name is Emilie, and I've been working at the Women's Heart Clinic since 2021 as a part-time coordinator and analyst with Dr. Sedlak. And I'm also currently pursuing a PhD in medical genetics at UBC.
Great. Thanks, Emilie. And so, yeah, again, hi, everyone. My name is Liz, and I'm a PGY3 internal medicine resident at UBC. And I'm joining the Women's Heart Clinic for research during my residency as well. And it is truly an honor to present with Emilie on behalf of the Women's Heart Clinic in Vancouver with regards to non-obstructive coronary syndromes and women's heart health, which are particularly passions of both Emilie and mine. We can move on to the next slide. Great. So with regards to the rest of the team, so Dr. Sedlak is the medical director of the Women's Heart Clinic. And we have the privilege of working alongside 2 nurse practitioners, Natasha and Rachel, and have access to psychiatry expertise with Dr. Wong. So introducing the Women's Heart Clinic here in Vancouver. So as highlighted by the team members involved, this is a multidisciplinary clinic and is based out of 2 clinic locations, one at the Gordon and Leslie Diamond Centre at VGH and the other at BC Women's. It has been open since 2012 and it is one of 6 formal women's heart clinics currently in Canada. And you can also see the distribution of these clinics in the figure demonstrated on this slide, which is fairly remarkable in terms of population access for those residing in Western Canada. Patients referred to the Women's Heart Clinic are women with chest pain and often in the setting of non-obstructive coronary arteries. So this leads to the first objective of this talk, to define the terms of MINOCA and INOCA, delineate the cardinal underlying causes, and with a comparison to obstructive coronary disease. Now, amongst the general public, ischemic heart disease is often interpreted as atherosclerosis of the coronaries, and even further to that, obstructive atherosclerosis. So I'd like to spend some time this morning describing the entities of MINOCA and INOCA. So MINOCA, or myocardial infarction with no obstructive coronary arteries, is defined by a few things. So first, the presence of an acute coronary syndrome, and this is as defined by the fourth universal definition of MI. So that's hallmarked by troponin positivity that is greater than 99th percentile and dynamic, plus more than one of a few listed items. So that includes symptoms compatible with ischemia, ECG changes compatible with ischemia, loss of viable myocardium on imaging, etc. Plus, you must have non-obstructive coronary artery disease, so that's defined as less than 50%, plus the ruling out of an alternative etiology, whether that be pulmonary embolism, demand ischemia, etc. Now, MINOCA actually represents a range of 5 to 12% of all MIs, depending on the literature. And it is a female-predominated entity, where it's 3 times more prevalent in women than men. Next slide, please. So this carries over to INOCA, or ischemia with no obstructive coronary arteries, and again follows that definition of non-obstructive coronaries of less than 50%, but in the presence of ischemia. So this is similarly more common in women, with approximately double the number of men undergoing angiography for angina to be found to have non-obstructive coronary artery disease. So as MINOCA and INOCA are umbrella terms, there are differential diagnoses amongst each. So for MINOCA, considerations include atherosclerotic causes like missed plaque rupture, non-atherosclerotic causes like coronary vasospasm, coronary emboli, spontaneous coronary artery dissection or SCAD, or etiologies with alternative mechanisms such as coronary microvascular dysfunction or CMD. So amongst INOCA specifically, coronary vasospasm and microvascular disease are the commonest etiologies considered. The reality is the majority of these diagnoses require access to specialized testing in order to provide confirmation, and this is by means of invasive coronary assessment with special techniques like OCT or coronary reactivity testing. So this type of testing is both specialized by means of the proceduralist and the technicians, as well as the capacity of the center for practical implementation. And so when we look at the demographics of patients presenting with MINOCA and INOCA as compared to coronary artery disease, we see that there are considerably less of the traditional cardiac risk factors that we think of and are taught in medical school, which include diabetes, hypertension, dyslipidemia, smoking, and a family history of premature disease. These figures demonstrate that amongst MINOCA and INOCA patients, the majority have either none or one of the traditional risk factors. And of note, the most common one is the positive family history of premature coronary disease, rather than the patients themselves possessing a comorbidity associated with elevated risk. Further to this, we see more non-traditional cardiac risk factors amongst patients with MINOCA and INOCA as compared to coronary artery disease, with the figure on this slide demonstrating frequency and reflecting the majority of MINOCA and INOCA patients possessing at least one of these risk factors. Bolded for your interest reflect the non-traditional risk factors with the highest odds ratios associated with MINOCA and INOCA compared to obstructive coronary artery disease. So for example, the odds of having migraines is 3 times higher in the MINOCA and INOCA group compared to the obstructive coronary artery disease group.
So thank you so much, Liz. I'm going to take over now for the second learning objective, which is to understand the interaction between mental health and MINOCA or INOCA etiologies with regards to the onset, progression, and perception of chest pain, also known as angina. So research has shown that there are sex and gender differences in how mental health impacts the risk of heart disease and time to diagnosis. So specifically, for example, women with depression are at a higher relative risk of developing heart disease compared to men with depression, and cardiac symptoms like chest pain, shortness of breath, lightheadedness are actually more likely to be misdiagnosed as anxiety, either self-diagnosed by the patient or also possibly misdiagnosed by the healthcare provider, as compared to men presenting with similar symptoms, leading to a longer time to diagnosis. So there's a lot to unpack there. I won't go into the why, but it's important to mention that this is actually exacerbated even more with MINOCA and INOCA when there aren't quote unquote obvious plaque causes to the disease. Further, although estimating a country's prevalence of depression varies by year, like for example, during COVID or not, and is subject to sampling bias, meaning like how representative is the statistical sample, the statistics of the sample being used to report the entire Canadian population. However, Statistics Canada does report consistently between 17 to 25% of Canadian women who have identified as having a history of depression. And notably, in our paper, 44% of our cohort with MINOCA or INOCA had depression at baseline, which is like roughly two-ish times more than this national average. So this is a pretty important issue, not just for heart disease, but just overall well-being and other comorbidities as well. So this is an important issue to talk about and think about. So there are several leading explanations for how, or theories, hypotheses, explanations, or mechanisms for how depression and anxiety can associate with a higher risk of heart disease, but also specifically the MINOCA and INOCA etiologies that are less plaque-based and more endothelial dysfunction and vasospasm-based. So basically in sum, it's a complex figure, but I'll break it down. For non-obstructive MINOCA and INOCA etiologies, there's a fine balance between the endothelium lining our blood vessels and the vascular smooth muscle cells beneath them, which controls how oxygen is delivered to the heart tissue. And disrupting this balance can lead to endothelial dysfunction and or smooth muscle cell hyperreactivity. So with endothelial dysfunction, this can mean enhanced vasoconstriction or impaired vasodilation. With vasodilators exemplified here as like nitric oxide, vasoconstrictors like endothelin-1, and there's things like vasoactive stimuli like acetylcholine, adenosine, serotonin, histamine, and not on this figure, but actually estrogens are also a vasodilator. So there's all sorts of chemical, like, hormones and things circulating in our body that can affect how our blood vessels dilate and contract. A few leading theories of how disruptions can occur due to mental stress include the concept of chronic low-grade inflammation, which can be induced or made worse by depression or anxiety through this like immunometabolic axis theory of depression. For example, if the body perceives itself to be constantly off-balanced in some level of stress, this can cause the brain to send signals for more stress hormones like cortisol and other stress hormones to kind of keep the body on high alert at a consistent low rate, which is not good in the long term. Second is the role of the autonomic nervous system. This is one of the involuntary arms of the peripheral nervous system. It operates on autopilot and it regulates processes like blood pressure, heart rate, respiration, etc. So when it's dysregulated, it can cause all sorts of symptoms that we don't really have conscious control over. And lastly, oxidative stress on the cells from other risk factors like smoking and diabetes can also contribute to these disruptions. So it is complex, and there is a component where some people might have a higher genetic risk than others to these disturbances, but that's an ongoing area of research. The perception of pain in the heart and elsewhere is subjective. It's a feeling kind of perceived by the brain that can be relative to the patient's past experiences. So this 0 to 10 pain scale might be familiar to some of you. It's kind of used across disciplines, and you might have been asked before, like, oh, like how bad is your pain on a scale of 1 to 10? And further, and this comes with a whole can of worms, and I'll go into the next slide, how we adjust a pain rating for chest pain. Further, the choice of language influences both patient and provider's perceptions of the cause of chest pain and what might be causing it. So for example, is it cardiac, psychiatric, musculoskeletal, is it lung-based? There's all sorts of reasons that could be causing chest pain. So there are linguistic differences in the verbs and adjectives people tend to use. So for example, men tend to describe chest pain more with words like crushing, pressure, squeezing, or tightness. whereas women tend to more often use words like aching, tightness, burning, or dull for their chest pain. That's for cardiac reasons. So it is possible that if different words are used, then that other diagnoses might be suspected. And this really does depend on the training of the interpreting provider, like the paramedics, the emergency staff, not just the cardiologists, but the entire healthcare team trying to bring this patient to seek medical attention. So instead of using the 0 to 10 pain scale, the Seattle Angina Questionnaire is a more cardiac specific measure that's more precise for measuring chest pain, that is subject more to the patient's self-report rather than the clinician trying to assess their chest pain. Historically, data indicates that prior to the SAQ, physicians both underestimated and overestimated patient symptoms. And this could be resulting in an overestimation of symptoms, causing more intense treatment than may be necessary, or inappropriate revascularization procedures like being sent to do angiography. And the opposite is also true. If they are underestimated, they might not be given the appropriate medication. So the SAQ was developed to address these disparities in some way and has been around for over 20 years now, almost 30. So it's quite used quite frequently. And it's usually asked of patients with stable ischemic heart disease. So we wanted to see how self-reported chest pain scores changed over time based on mental health status, specifically depression, with the hypothesis that patients with depression would have higher self-rated pain, reflecting in lower SAQ scores. So the SAQ converts questions answered on a 5-point scale to a 100-point scale, with lower scores indicating worse angina, and has 4 subdomains: physical limitations, angina frequency, quality of life, and treatment satisfaction. So we applied the SAQ in our population of MINOCA and INOCA patients in our clinic and found overall improvements in all subdomains after 3 years. I do want to mention that we did define depression as a composite of having a clinical diagnosis by a doctor, psychologist, or therapist, and or having a score of greater or equal to 10 on a depression questionnaire at baseline. It's called the PHQ-9 Patient Health Questionnaire, and or if the patient was currently on an antidepressant. So we use this composite definition as it was demonstrated in previous literature to be more robust than just using a single definition. So our hypothesis was correct. We did find that patients with depression, as indicated by the red lines in the figures on the right, had significantly worse chest pain at baseline compared to patients without depression. However, in a good way, both groups did show significant improvements in a positive direction after 3 years in all of the subdomains. And lastly, for this section, we also saw differences in the reported context of the chest pain, meaning whether exercising, sleeping or resting, or with the most stress or emotional triggers. So INOCA patients had significantly more exertional chest pain than MINOCA, who had more non-exertional components. And within looking at the more specific diagnoses, vasospasm had more non-exertional chest pain compared to patients with CMD, coronary microvascular dysfunction, who had more exertional chest pain. So non-exertional is referring to like at rest or sleeping, and exertional is kind of when like low-grade exercise, it could be walking up a hill, it could be running. Exertion just kind of means like in movement. And the groups did actually also have similar rates of stress or emotional triggers, around between CMD and vasospasm, it was around 26% each. And this is important to note as there are emerging ideas that there are sex differences in how many people report stress triggers, with women more likely to report these. And this has important implications as these triggers can precipitate changes in blood pressure and heart rate, and these can be triggers for chest pain events in some patients. So for our final section, Liz and I will split up how we describe our results from our 3-year paper. We're going to go over the components of a specialized women's heart clinic and its impacts on the outcomes in the women studied with MINOCA or INOCA. So we do have this paper currently undergoing peer review, but it can be read on medRxiv as seen below. So the majority of our patients who came into the women's heart clinic at baseline did not have a diagnosis. They had suspected something's going on. They had an MI or they have chest pain that's been confirmed cardiac, but the referring physicians weren't completely sure what was going on. So this was an incredible improvement from 80% to 4% receiving a specialized diagnosis, the majority of which were coronary microvascular dysfunction at 56%, followed by vasospasm at 26%. So an important footnote is that spontaneous coronary artery dissection, or SCAD, is quite a common etiology of MINOCA for women under 55. There's a statistic that 90% of patients with SCAD are women under 60. So it's quite, it's an etiology that's quite skewed for reasons that are a bit beyond the scope of this presentation. But we want to just highlight that within the 13% that SCAD patients are in this graph on the lower right, the reason we have fewer patients in our women's heart clinic longitudinally is that as soon as they're identified as having SCAD, they are referred to a dedicated SCAD clinic at VGH, run by Dr. Jacqueline Saw. So Dr. Sedlak and Dr. Saw kind of refer to each other. As soon as they figure out SCAD, they kind of go to the other clinic. So these results do reflect our clinic's access to the specific testing modalities and specialists required to make these diagnoses and interpret the results. So earlier in the presentation, Liz introduced the concept of procedures like OCT and coronary activity testing. So with coronary flow reactivity testing, this is done during angiograms and is very finicky. Basically, people administer specific agents that can induce and then reverse vasoconstriction or vasodilation in a controlled environment. And while they do so, they're quantifying how the blood vessels are reacting, both big vessels and the small vessels, microvasculature. So when you're able to induce these things and then reverse them, you're able to actually have a number and pictures, like numbers quantifying how severe the microvascular dysfunction or the epicardial dysfunction is. And there are kind of different thresholds for what's considered abnormal. But yeah, that's an example of why there could be so many undiagnosed coming into this clinic. And then next, we converted SAQ scores to something called the Minimal Clinically Important Difference Metric, the MCID. And basically, this is something that varies by questionnaire. For the SAQ, this means an increase or decrease in more than 10 points is considered clinically relevant, like they improved in a clinically meaningful way that could impact other comorbidities. So as you can see here in this figure, all patients, the majority improved, or there wasn't a significant clinical change in gray. And we did see more improvements overall in INOCA patients than MINOCA patients. As indicated on the right hand of the graph, there's a bit higher proportion of dark purple. And we have a couple of possible explanations for this that we're considering. One is that there's more heterogeneity in the MINOCA etiologies, meaning there's more differences of plaque rupture, SCAD, vasospasm. Some people have CMD. And with these different diagnoses come different considerations. For example, which medications are recommended, the predictability of chest pain, all those kinds of things can affect the SAQ. Specifically, for example, with vasospasm having more non-exertional, it's kind of more or less predictable, and there are a higher proportion of vasospasm patients in the MINOCA group. So those are kind of theories as to explaining these results. And now I'm going to turn over back to Liz.
Awesome. Thanks, Emilie. So another aspect we were interested in was the impact of the Women's Heart Clinic on healthcare utilization. So that's by means of ER visits and cardiovascular hospitalizations. So literature has previously demonstrated that women with chest pain and non-obstructive coronary syndromes frequently utilize hospital resources. And we were curious if through enrollment in a specialized women's heart clinic, this could be reduced. And so our results have reflected exactly that, with a significant reduction in ER visits for both MINOCA and INOCA patients after 3 years of follow-up, and in comparison to the equivalent time period prior to baseline visit. INOCA patients were also found to have significantly reduced cardiovascular hospitalizations. MINOCA patients did not confer the same statistically significant reduction, and that's owing to the low baseline rates when you exclude their index hospitalization. In terms of prescribing practices, this was another area of interest and how this may differ for patients following enrollment in a women's heart clinic. So with regards to MINOCA patients, we see a less dramatic of a change in medical therapies as compared to INOCA, which you'll see on the next slide. And this is likely owing to a more standardized care in the setting of hospital admissions for myocardial infarction and the immediacy of access, at least at our institution, to an invasive coronary assessment and further testing beyond that. So nonetheless, short and long-acting nitrates were commonly prescribed medications after enrollment in the Women's Heart Clinic, and these are well-recognized agents for their anti-anginal properties. Non-ASA antiplatelets were commonly deprescribed medications, and this is supported by the lack of substantial benefit in the available literature. While not really reflected well on this graphic, beta blockers were one of the greatest prescribed and deprescribed medications over 3 years of follow-up. And this is reflective of the nuanced decision in this regard. So there's really current inconclusivity in the available literature as to whether beta blockers truly provide a beneficial impact for MINOCA patients. And currently we're awaiting the results of the MINOCA BAT trial, which will help us further delineate the utility of beta blockers in MINOCA patients. So you may notice in this graphic on medical management changes in INOCA patients, there's more obvious additions of medical therapies after 3 years of follow-up in the Women's Heart Clinic. And one postulated reason for this is that there's less standardization for management of troponin-negative angina, particularly so in the uncertainty that's often paired with women experiencing chest pain in the absence of traditional cardiac risk factors. So after 3 years of follow-up in the Women's Heart Clinic, we observed the commonest prescribed medications amongst INOCA patients to again include short and long-acting nitrates, but also ranolazine, which is a selective inhibitor of the late sodium current and an adjunctive therapy used in chronic angina. We also saw calcium channel blockers commonly prescribed in INOCA patients, and this was a practice that wasn't observed in the MINOCA patients, but I should note that nearly half of MINOCA patients entered the Women's Heart Clinic already on calcium channel blockers. So that's further supporting the notion regarding standardization and more ready access to appropriate therapies amongst these patients. Otherwise, most commonly deprescribed therapies, again, include ASA and beta blockers, and that's reflective of the evidence or really lack thereof for these agents. So this figures from the 2024 CCS clinical practice update on MINOCA, and it reflects the present available treatments for the etiologies of MINOCA, which overlap to a considerable degree with that of INOCA as well. So these are kind of touching on things that I just described on the last slide. But I do think it's important that we acknowledge that this patient population is a historically understudied and underrepresented population, and randomized clinical trials are really quite lacking when it comes to guiding recommendations. What adds further challenge is the comorbidity profile that Emilie has also highlighted between the etiologies within MINOCA and INOCA. They differ quite a bit when it comes to comorbidity profiles, for example, between vasospasm, embolism, missed plaque rupture, which of course adds further complicating matters. Beyond this, the side effect profile, those two often, of course, require customization. And while outside of the scope of this talk, we're presently conducting a side project investigating adverse reactions amongst this patient population. There's also ongoing research aimed at understanding the underlying pathophysiological mechanisms from a genetic perspective, a genetic lens. And all this to say, there's no one-size-fits-all solution, and further data is really required, which we hope will come with the increasing awareness of MINOCA and INOCA and attention from people like yourselves. So I just wanted to say a huge thank you. Emilie will say thank you as well. Really such a privilege to present today. So thank you all for your attention.
Thank you all as well. And yeah, our emails are on the screen if you do have any follow-up questions. Thanks again for this opportunity to share our research.
Does anybody online have questions for our speakers? You can pop it in the chat and we'll read it out, or you can just unmute yourself and go ahead and ask. Maybe I can just kick it off with a question that I had right close to the beginning of your presentation. You mentioned more women experience these non-traditional risk factors that have, you know, heart issues later. And I think your comparison was the females having heart issues to the males who have had similar. I was just wondering how the non-traditional risk factors compare amongst women who have heart problems and don't have heart problems. Like, I'm just wondering if these risk factors are just more abundant in females in general, or if they confer increased risk from a heart health profile, if that makes sense.
It's a great question. Liz, do you want to take a go at it, or do you want me to take a stab at it first?
I'll let you take a stab first.
Okay, sounds good. I think we both have different lenses. So I think both of us can contribute an answer. So in my research, I actually did a master's thesis around this topic too. And I did some more further research in the Women's Heart Clinic for the sex-specific risk factors. And to answer your question short, yes, having these non-traditional risk factors that are more common in women does increase your relative risk of heart disease. So for example, migraines are around 3 times more prevalent in women than men in the general population. And it's actually the most striking non-traditional risk factor in the vasospasm and microvascular population. It's like 3 times higher than the population average. So just because you have one of these comorbidities doesn't mean you'll get heart disease. It's all relative risk, right? So if you wear sunscreen, you're lowering your risk of skin cancer kind of thing, right? Things like preeclampsia are sex-specific risk factors. They're pretty well correlated with increased risk because of the hypertension. And there's also sex-specific effects on increased risk in certain variables more in women than men, and vice versa. So diabetes and smoking confer higher relative risk of developing heart disease in women compared to men. And men with hypertension and dyslipidemia, high cholesterol, are more likely to develop heart disease than women with dyslipidemia and hypertension. And from my understanding, this is pretty robust across different like racial ethnic populations as well. They've tried to replicate these findings in like South Asian, East Asian, European, African cohorts. And something we didn't touch on in this slide are these race ethnic genetic ancestry differences. Some people are much more likely to develop heart disease for reasons that are still being explored. Like, for example, South Asians typically have 2 to 4 times higher rates of heart disease than European ancestry populations. And people are speculating how much these traditional and non-traditional risk factors have to do with that. Yeah, Liz, do you have anything else to add? Or?
No, I figured I'd let you answer because you have graduate study experience.
Okay.
That's a great answer.
Yeah, exactly.
Awesome,
that.
okay.
We do have a question online. Maybe I can just read it out for you. So Beth Payne, hi Beth. She put in the chat that she was struck by the map of Canadian services for women's heart health and curious how the clinic in Vancouver is managing demand. Do you have a significant wait list?
Yes, very, very topical. I know that there are additional women's heart clinics in the works that have not yet made themselves on that figure because they're not formal and up and running, is my understanding, Emilie. But yeah, everyone across the country and from like a health access and funding perspective is aware of that discrepancy. And there are clinics in the works to have more access from Western Canada.
Mm-hmm. It is quite shocking. And one thing that Dr. Sadlak is really advocating across BC is education of other cardiologists and emergency physicians to just be aware of these sex and gender differences, to kind of be able to spot these differences. And part of the lack of specialized clinics is also due to partly because we don't have a specialized fellowship apparently in Canada for women's heart health. So apparently all the women's heart clinics that are run by cardiologists who have a quote unquote specialization in women's heart health, they all had to do their training elsewhere. Like, so Dr. Sadlak did her fellowship in women's heart health at Mount Sinai in California. So I think that's another reason for the discrepancy of women's heart clinics and lack of specialized cardiologists in Canada, is just because we don't have a national fellowship available yet. Liz, correct me if I'm wrong, is there something in the works? I think there's something in the works somewhere.
There is something in the works. I won't say anything further.
Yeah. So yeah, I hope that answers your question.
It's really exciting.
Mhm.
We'll await news of that in the future. Anybody else with any questions?
I have a question.
Great.
So I heard on, I think, CBC News Radio several days ago that there is doctor in BC that started the petition to have obesity drugs in BC paid by the government. I think she's specialist in diabetes. You stated that diabetes is one of the risk factors for women. Do you think having obesity medication cost covered by the province will help resolve this issue with this important risk factor and maybe reduce long-term the rates of heart disease in women?
Liz, do you want to
Did
take
you
that?
hear the question?
Yeah. I mean, I think like access is often a huge barrier to patients. So for sure, if we can improve access wherever we can, that would be very ideal. I think access to medications is one thing, and then also kind of as we've highlighted, recognizing the features of these syndromes is also super important. So it's as with most things, it's going to be a multimodal approach to reducing like long-term cardiovascular endpoints. So both access to medications, but also making sure our healthcare providers are aware of the symptom profiles to look out for, referring to the Women's Heart Clinic if they need further assistance with diagnostic clarity. So I think it's always going to be the multimodal approach there, but certainly agree access to medications would be helpful for a few reasons.
Excellent. Any other questions from the folks online? Just checking the chat. I think I might have heard Dr. Sedlak talk about this previously, but I'm just curious, along with the clinic, is there any connection to kind of lifestyle modification treatments as well? So things like physio or exercise rehab or things of that nature?
That's a tricky question to answer because interestingly, a lot of our MINOCA and INOCA patients have a pretty healthy risk factor profile. A lot of, especially the younger women under 60, aren't typically having the comorbidities that would benefit the most from cardiac rehab. So for example, a lot of them don't have, like some people do. So those that do, definitely they can, like if you have diabetes, if you have a BMI that's a bit uncontrolled, like there's definitely ways that we can in an intersectional multidisciplinary way, try to support patients in terms of lifestyle habits and improve like exercise and diet. But it is a population that is typically on the healthier side. It's as far as risk factors. So one thing that we have underscored is mental health and this idea of stress and the vasoreactivity. So we really do emphasize and encourage a mental health safe space in the clinic with access to the psychiatrist, peer support hubs. We do really recommend women connecting with other women if they're comfortable with that, with the same diagnosis, if they want to share their lived experience. Because there is some differences, sex differences in the biology of how reactive our blood vessels are to emotional triggers and stress. There's some hypotheses about, these sex differences based in how our bodies have to be able to adapt to pregnancy and an increased stress, like, pregnancy is the nature's stress test, right? Like we have differences in how reactive our blood vessels are. So I think stress management is one of the #1 recommendations we do to work with the patients to, in like a non-medicalized way, improve their risk.
And I'll just touch briefly from like a cardiac rehab perspective. Like oftentimes it's beneficial more so in the setting of like improved comfortability and like safety in terms of returning to exercise. So often these women are just unsure if is it safe, like I'm getting this chest pain when I do this degree of exertion. And so there's a lot of anxiety around returning to exercise and returning to a healthy lifestyle after an event or after a big bout of an ischemic chest pain. So I find cardiac rehab can be quite helpful in that setting, where they get that confidence back in terms of their degree of exercise.
Yeah, that's great. We do have a question that's popped into the chat. Is there any movement in other disciplines to support this specialty training in Canada, thinking of nursing or allied health?
The Canadian Women's Heart Health Alliance is a resource I would recommend anyone interested in this to check out, the CWHHA. They are a national, it's a non-for-profit, but they're basically led by a team out of Ottawa, and there's tons of interdisciplinary nurses, cardiologists, EMR, emergency, paramedic, just all trainees, researchers involved in creating this infrastructure. And there are a lot of training programs and classes and lectures that this national team are trying to create and implement at a national scale in these different settings. And it's usually on a volunteer basis. However, there are a couple trainees. I know there's a cardiology fellow out of Ottawa who's making a women's heart health curriculum for cardiology students. Like, there isn't really a dedicated unit apparently on all this yet. And I think I have friends who are in the nursing curriculum who are also trying to create lecture series to pitch to their program directors, please integrate this. So I know that's happening behind the scenes, but it's still, there's a lot of content that administrators have to consider when integrating into things. So it's still in the works. Liz, do you have anything to add?
Yeah, really just to highlight that this is such an up and coming field and fairly recently recognized. Like it's something that wasn't really in the medical school curriculums even like 5 years ago. And so with increasing position statements and what have you, there is increasing awareness. But any sort of training program takes several years to create. So I think we're getting there, and hopefully in the coming years they'll start to appear, but these things unfortunately take time, and we're just starting to come to a very exciting place, but where there's actually increased awareness of these conditions.
Great.
I have a question. Hi, everyone. Thank you so much for the great presentation. It was really thought-provoking. I have one question about, actually, I'm curious to know a little more about how the data is being collected in these women-specific clinics. Like you pointed out that there are lots of nuances and some risk factors, which are more distinguished for women than men. And I was just curious to know, are like the data fields or data variables in these clinics any different than what's being collected from like a general clinics, or from men compared to women? Just
That's a great question. It's a really good question, and the bane of my existence when looking for a control group to compare against. Yeah, so the nature of research is so we're trying to control for being consistent between inter-researcher appraisal and collection of these variables for when we're doing analysis. And I've really tried to standardize this approach in the last few years. We do a mixture of electronic health record mining. So we do base our initial scan of risk factors based on Dr. Sedlak's reports and their Dr. like Prodembala, like the nurse practitioners. We look at the Women's Heart Clinic, what the patients are reporting in their initial visit. And then additionally, I do look at the referrals that are faxed in to our clinic. Sometimes there are some diagnoses that are historical that aren't currently present, but I sometimes write those down too. And lastly, I do confirm all of this by self-report with the patient. Self-report has its own biases. People might have misunderstandings, like forget their timelines, but typically I've had a lot of patients expand and actually clarify diagnoses that might have been misconstrued in the clinic notes in the past. And we do use a REDCap database to kind of standardize all the inputs of the data fields. So when we're comparing within our database, it's all pretty standardized and uniform. The problem is when we're comparing between cohorts and between data sets, like with PopData-BC, which we have not done, but I've considered. The study with the risk factors, with those graphs, with the obstructive CAD compared to MINOCA and INOCA, we actually compared young women under 55 from our clinic to a cohort called SAVE-BC. It's a study I used to work with a while ago that looks at only obstructive coronaries. And they did not consistently capture migraine data, for example, because the physicians don't usually ask it. Same thing with sex-specific variables. They didn't often capture menopause. So we couldn't report the menopause statistic either. Premature menopause is a risk factor for heart disease, but we couldn't show that because the other study didn't ask it consistently. And this is not unique to that study. You know, Shay, they're a great study, great team. It's one of those reflections of many variables that aren't asked. PCOS, endometriosis, like history of premature births. Like these are all risk factors for women that aren't consistently asked across different studies, which depends on the research questions. So I hope that answers your question about how we collect it, but also some thoughts about how other studies do it as well. Yeah.
And do you think if this system, I mean, the health system in Canada is ready or aware enough of this discrepancy, or like how far we are from that learning health system, which is more specific to women than men? You know, I mean, in terms of these specific clinics, do you think the health system is aware or ready, or how far we are away? Yeah, just curious.
Yeah, I can speak to that. I mean, I don't think we should, I'll just say, I don't think we should ever wait until the healthcare system is ready. But I think like in terms of awareness, what I have noticed is like there is an awareness of women's heart clinics, especially even, for example, like an out-of-province elective in Alberta. The cardiologist there knew about Dr. Sedlak and the Women's Heart Clinic in Vancouver, even though there's no currently up and functioning Women's Heart Clinic in Alberta. And so there is an awareness, and I've found also around BC, like when there is a woman with chest pain, it's thought to be cardiac and etiology, maybe there's proven non-obstructive coronaries, there's an awareness, oh, there's a women's heart clinic, let's refer this patient there for further diagnostic clarity and assessment. So I think that awareness is growing, and it is present in terms of the true like sex-specific risk factors and, you know, the increased prevalence of these conditions in women. That is up and coming, but I don't think it's as recognized as necessarily the presence of a women's heart clinic, if that makes sense. So I'm hopeful that now with these, like, for example, the recent clinical update that was published just back in June regarding MINOCA, there was a great MINOCA review in 2019. Like all these things are fairly new and getting traction, and I'm hopeful that with time that awareness will improve too. But it's a slow process, but we're trying to move it along as fast as we can.
Yeah, no, very impressive, especially, you know, with your research and similar research studies that are getting us closer to where we are hoping to be. Yeah, absolutely. Thank you.
Is there any other questions from the group?
I have a note. If
Okay.
you want to link your data with administrative data, contact me. I can give you a lot of good tips how to do it correctly and get all the data you need.
Yeah, Sabina's our biostatistician and has a lot of experience working with PopData-BC data. So if you do ever want to go down that road, for sure, reach out to Sabina.
Will do. I've been thinking about it for years. The question has always been sample size. So I think in a few years, once we have right sample size, we can revisit this.
Excellent.
Yeah.
Okay, well, I just really want to thank you for this amazing, thought-provoking presentation. We've had lots of great questions and great discussion. So thank you so much. And please do keep us in the loop if there's more findings that you have down the road. We'd love to showcase them. It's such an important area. Thank you so much.
Thank you so much. This was a great opportunity and great discussion. Yeah.
Have a great morning, everybody.
Thank you. Bye.
Bye.